Friends, I am Dr. Amdekar, and in this video I am going to revise some important facets that my colleagues discussed in the last 6 topics over the last series. To begin with, Dr. Sridhar Ganpati talked about a lymphadenopathy. Friends, make sure that you are dealing with a lymph node in the neck because sometimes other masses may also simulate. Typically, a parotid swelling may be confused with a submandibular lymph node. Once you are sure that it's a lymph node, make sure that it is a significantly enlarged. The significantly enlarged is largely by size, a size more than 1 to 1.5 centimeters in the neck and at other sites more than a centimeter are considered as significant, but more than that, the site could be very different, and even if it's small, like a supraclavicular or an epitrochlear or a popliteal lymph node, then whatever size it is always to be considered abnormal. And further, even the smaller size, but if it is tender or if it has a different consistency, then you consider it as abnormal. Once you consider that a lymph node enlargement is significant and abnormal, you decide whether it's a single lymph node. And friends, don't forget to palpate every other site in the body because the presentation could be only one in the neck, but you might even find out that there are lymph nodes of significant size at axilla or inguinal region, etc. And it obviously becomes pathological. Similarly, don't forget to look at the liver and spleen and many other abnormal findings that may give you a clue to the probable etiology. Thereafter, Dr. Chokhani discussed about hepatomegaly and he emphasized that hepatomegaly is an increased liver span which is evident by percussing the upper border and palpating the lower border, and the liver span varies right from 6 centimeters at birth to about 12-13 centimeters in an older child or an adult. Once you confirm that the liver is enlarged, because liver may be palpable per abdomen but just pushed down, and that's not an enlarged liver. Once you confirm it's an enlarged liver, you decide which part of the microanatomy is likely to be pathological, and that is it hepatocytes, is it biliary tract, is it reticuloendothelial system, or a venous congestion. Each of these microanatomical sites have a characteristic findings along with hepatomegaly, and he also emphasized that a large localized mass in the liver like a hepatoblastoma may not have any liver dysfunction of any kind, and therefore you also look at whether the patient is sick or not sick and whether patient has any obvious liver dysfunction or not. Thereafter, Dr. Khare discussed about splenomegaly. Friends, we all know that spleen becomes palpable per abdomen only when it is enlarged 2.5 to 3 times the normal size. But can we not pick up a mild or a moderate enlargement of the spleen which is not even palpable per abdomen? It is possible by percussion, and you percuss on the left side in the lower intercostal spaces, and most important is when you percuss, let the patient every time take a deep inhalation, and if a percussion note remains impaired even on deep inhalation, normally it should be resonant, then you start suspecting whether it could be an early splenomegaly, and you can confirm it with an abdominal ultrasound. Of course, it could be also due to a small pleural effusion on the left side, and you need to differentiate between all that. Well, when the spleen is large, it presents as a lump in abdomen, and unlike the liver, which presents as a generalized upper abdominal distension, liver being a very superficial structure and enlarges diagonally from left hypochondrium towards the right iliac fossa, it always presents as a lump in abdomen, and then you know that when you have a firm large splenomegaly, it could be due to either portal hypertension, pre-synodal or sinusoidal. It could be also due to any infection like malaria, kala azar, or any other disseminated infection. It could be due to storage disorder, or finally, it could be also hematological disorder, but one important disorder that you can easily overlook is a chronic myeloid leukemia, which presents only as a splenomegaly without much sickness, without significant anemia or any evidence of thrombocytopenia. And I think don't forget to rule out a possibility of a chronic myeloid leukemia. Thereafter, Dr. Tushar Manihar discussed cardiomegaly, and he said that there are no symptoms of cardiomegaly, but the cardiomegaly symptoms come up only when there is a cardiac dysfunction. He discussed how to differentiate between a cardiac dilatation and cardiac hypertrophy, and also emphasized how pericardial effusion looks like a cardiomegaly, but when the percussion note goes beyond cardiac borders and you have many other correlated findings, you can diagnose pericardial effusion, which mimics as a cardiomegaly but is not any myocardial disease. Then he also said that a myocardial disease may be primary myocardial affection, or it could be also secondary to anemia, or it could be a part of a generalized muscle disorder like a Duchenne muscular dystrophy, or even a hypertension can cause cardiomegaly. Thereafter, Dr. Palni Raman discussed the interpretation of murmurs. Friends, we all know that functional murmurs are not uncommon, and they are often soft systolic, short systolic, and they often change with position. But one other murmur that often makes us mistake it for a cardiac pathology is a venous hum, and this is due to increased blood flow across the internal jugular vein. Such a continuous sound is best heard only supraclavicular or an upper chest, and when you make the patient lie down, the venous hum completely disappears because the internal jugular vein collapses on a lying down position, and venous hum reappears when the patient is made to sit up or be erect. Once you know that it's a pathological murmur, it could be a normal valve where there is an abnormal flow across the normal valve, or of course it could be an abnormal valve itself, or sometimes it could be really related to a congenital defect like a septal defect. Once he discussed all this about interpretation of murmur, Dr. Anjali Gokarna discussed the interpretation of chest findings, and she emphasized how inspection and palpation for various diseases have similar findings. When you come to percussion, you have a difference easily between impaired note of collapse, consolidation, effusion, etc., as against a hyperresonant note of emphysema or a pneumothorax. But auscultatory findings are very tricky because there are common findings for multiple different pathologies, and sometimes some pathologies have a very minimal finding. She emphasized that every abnormal finding should have a further evaluation of either a pleural distribution or a lobar distribution. This is related to a surface anatomy of the lung. And once you know that it's a primary lung parenchymal versus a pleural disease, then you can interpret the findings very well. But she also emphasized how a developing pneumonia may not have a bronchial breathing or increased VR or TVF, and similarly, a recovering pneumonia also may not have those signs except few crepitation. She also mentioned a cavity can have no signs at all if it's a small and deep-seated cavity, or a cavity may only have an impaired note but no bronchial breathing, no amphoric breath sound, no increased TVF or VR, because if the bronchial segment connecting the cavity is blocked, then there are no other auscultatory findings. Friends, then all such findings need also very thoughtful analysis and the correct interpretation. I hope you are enjoying this series of a different types and a different analysis, and I hope you continue to be with us and keep on spreading this information to your colleagues. Thank you very much.